Ainsley.
Sounds good. So today I get to talk about selective mutism in the context of children with autism. And I'm really excited that someone even invited me to talk about this topic because nobody's talking about it. So I'm really pleased to be here today. The focus today is really going to be on the treatment aspect of selective mutism, and it's a behavioral treatment. So I really want to emphasize that this should not just be something that quote-unquote experts are thinking about. It should be what BCBAs are thinking about. It should be what psychologists are thinking about. It should be what parents are thinking about. And I will talk a little bit about how to sort of know if you're dealing with selective mutism, but it won't be a big emphasis on the assessment piece. And then I'll end with a treatment case study of somebody who I treated with selective mutism and autism. So let's talk about the diagnostic criteria. So this is, according to the DSM-5, first of all, it's important to know that selective mutism is under the umbrella of anxiety disorders. And that was actually only the case starting in 2013. Was the first time that selective mutism was in the anxiety disorders umbrella. And I think the really important thing to think about with selective mutism from a diagnostic point of view is that this is a failure to speak when the child has some language, right? And so it's not that they've just never spoken ever under any circumstance with any person, is that they have some language at whatever level they've obtained it, and they are failing to do so in certain social situations or with certain people, despite the expectation to do so. Like most diagnoses, it has to interfere in some way, because if it doesn't interfere with their life, then kind of who cares? And needs to be present for at least 1 month, not the first month of school, which is wonky for everyone, parents and kids included. Autism or no autism, first month of school is pretty wonky. And it can't just be due to lack of comfort with the language, that kind of thing, and not better explained by a communication disorder. So again, we know that language is, it develops differently in kids with autism. They may not have the same complexity of language or use pragmatic language the same way or social communication the same way. But if a child with autism, let's say, has phrase speech, or they can say, I want apple or me want apple, that is language that is used. And if, let's say, they can use that language with their parents in a few occasions at home and most of their siblings, but at school they don't use that phrase speech at all, then we start to be thinking about selective mutism because they have some language, but they're not using it across contexts in a way that they should be able to. And they're losing really valuable opportunities to use whatever language they have at whatever level they've attained it in environments that really matter for them. So in terms of selective mutism, we know that there tends to be more girls than boys who have it, and it occurs in about 1 in 143 children. This is based on a US study. And there is, in terms of, we know that SM does occur in autism. There aren't great studies that are looking at this. And there's lots of reasons that that happens, one of which is we often miss selective mutism in autism because people just really chalk it up to, oh, well, they have autism, so they can't possibly have other co-occurring conditions, which is not true. Or they just assume that their lack of speaking is because they never developed language or their language skills are behind. But we know that anxiety is one of the most common co-occurring problems in school-age children with autism. And we do know that selective mutism, developmental disorders, and other kinds of anxiety disorders often co-occur as well. Something else that tends to happen in this population, and this is not specific to selective mutism, this is a problem in kids with autism in general, is people, the idea of diagnostic overshadowing is that people will just assume that everything that they see is because of autism. So once the label of autism is applied, they stop looking for other things. And that is a problem because if a child has autism and OCD, or autism and depression, or autism and selective mutism in this case, those are specific. If we have a label to it, or at least some sense of that, then we can actually give treatment to that specific thing. And the treatment of depression versus OCD versus selective mutism looks different, and the evidence tells us that different things and components need to go into those treatments to really help these kids. And when I think of autism, there's already these pervasive deficits across social communication domains that if we have something that we know we can treat with a behavioral approach in, let's say, 12 to 20 sessions, and one part of their life can drastically get better because we give them a diagnosis of something, that's something that's really important. And so a lot of times, even really skilled clinicians will miss selective mutism. Some people even don't know how to diagnose selective mutism, or they think that it's not possible to diagnose in autism, but that's just not the case. So kind of what I mentioned, the importance of catching selective mutism in autism. We know that selective mutism, the age of onset is between around 2 and 4 years. Usually it's not caught in those years, but for sure between 2 and 6. And just like in autism early intervention research, the sooner we catch it, the better we can break this cycle of negative reinforcement. So I'm just going to give a quick sampling of this negative reinforcement cycle. And this is from Dr. Ketchpool, who does a lot of work in SM at BC Children's Hospital. So you can see here that what happens with these kids is somebody will ask a question. There will be a speech demand. So a mom might say to their kiddo, do you want a cookie? And what happens then is the child's anxiety spikes right away. They might even get to a 10 out of 10 if 10 is the most anxiety possible. The child then avoids, so the child just does not answer the question. And the adult feels really uncomfortable. They really want to know if their child wants the cookie. They're thinking, oh, I can't handle this. Maybe the parent has a low distress tolerance. Maybe they're worried that their child is hungry and can't tell them. So then the adult will jump in and just give the child the cookie without needing a vocal response, a verbal response from the child. Or maybe they'll just accept a nonverbal response by shaking their head, yes or no. And then the child will get the cookie. Everyone feels better. Parents' anxiety comes down. Child's anxiety comes down. Child has then learned that they do not need to use speech to get the cookie. And then the cycle continues. So it really is a cycle that kids can't get out of and parents can't get out of. A lot of times people think that selective mutism, oh, they're just shy, or they'll grow out of it at some point. Perhaps that's possible in a very small percentage of cases. If you just think of it from a very behavioral point of view, I mean, I don't think I'd talk if someone gave me cookies and I didn't have to talk too much, because it's especially if you think that already that language might be hard for these kids. Their brains already start out different. Oftentimes, temperamentally, these kids are a bit more on the anxious side to begin with. Parents might be a bit more on the anxious temperament side as well. They might have low distress tolerance. They know that their child has autism, so they're already in the mode of needing to be sometimes overprotective, sometimes appropriately protective of their kids. And nobody can get out of this loop unless somebody breaks some part of the cycle. And so the earlier we can catch this negative reinforcement cycle, the better. We also know that there's so many missed learning opportunities. So every time a child is not able to talk, let's say at school, but they're able to talk at home, then they miss learning opportunities from adults, from other kids. We know that daily functioning skills, which are already behind, and so many kids with autism lag further and further behind. So the longer the lag, it's harder to treat the longer the lag. So let's talk about what is the evidence for treatment of selective mutism. And what I'm going to do is talk about what the evidence is, and I'm going to talk about what the evidence is in kids who don't have autism. And then I will talk about what I did in my treatment with this young man who had selective mutism and autism. Because to cut to the chase, there's no research in treatment of selective mutism in autism and selective mutism when it's combined in one kiddo. So we kind of have to abstract what has happened in one setting with the other population. And even in selective mutism for kids without autism, the research is not that advanced. So there has been 2 RCTs, and there's been 3 treatment-specific reviews. And in terms of the randomized control trials, which we know is sort of the gold star of trying to understand whether an intervention works. So Lindsay Bergman, in 2013, she did a study, which is behavioral. So all this is behavioral. She did this at UCLA. There were 21 kiddos in this study. Again, this was a group of youth who were, as far as I'm aware, sort of neurotypical, except for the fact that they had a diagnosis of selective mutism. The kiddos were between 4 and 8 years, and they did 20 sessions across 24 weeks. And she compared a behavioral treatment versus a 12-week waitlist control group. And there were no school visits in this particular study, but they did lots of coordinating with teachers and therapists and parents. And she found that there was a 67% remission rate in the behavioral intervention group versus 0% remission rate in the waitlist group. So behavioral intervention was definitely better than the waitlist control. And then there was a study done by Orbach in 2014, and this was again it was 24 kiddos. They between the ages of 3 and 9, and 21 sessions. And in this study, the psychosocial intervention was better than the waitlist control. And in this study, the younger children between 3 and 5 did better than the kiddos in the 6 to 9 range. But the kids in the 6 to 9-year-old range still got better. And all of these studies, the focus is on increased functional speech. That's really the goal. In terms of what are the core treatment elements, so again, reminder that this evidence base is not based on kiddos who have ASD, but behavior therapy. So behaviorism. If you have a behavior background, you're in the right place because you really want to be thinking about behavioral elements in this treatment. There are a lot of sessions. So when you think of that cycle that happens, kids have spent a long time stuck in that negative reinforcement loop. So it does take some time to kind of break that loop and learn otherwise. Often there's video, self-modeling, play, role play. A lot of times with these kiddos, medication, there is a role for medication because the anxiety also tends to be quite high. Or if they've tried behavior therapy and they're just really, really stuck, sometimes a little bit of medication, whether it's fluoxetine, and that's not my background, just as a caveat. I'm not a psychiatrist and I'm not trained in medication, but sometimes a little bit of an SSRI will just, just kind of get those kids just enough of unstuck from that kind of freezing response to engage in the therapy. And it's really important to have this intervention across home, clinic, and school. The generalization piece is really big, even for the population that don't have autism. And the whole goal is to break that loop that I talked about. So lots of this is going to look familiar to all the behaviorists watching. It's truly a behavioral intervention. So we want to make sure we have contingency management. So if you ask a child a question, you really want to make sure you get that response before you give them the thing that you really want. So breaking the loop of the child getting the cookie without using words. The language and the cool object, the really delicious cookie, should be contingent. There's also a big shaping element to this treatment. So we might start with shaping just word approximations, so just parts of a word, or we might start by having the child whisper the word to their parent, and then a little bit louder, and then maybe an unfamiliar person stands outside of the treatment room and then gradually gets a bit closer as the child is talking louder and louder. But there really is shaping from distance to the talker, who the talker is, how loud the voice volume is. And then we have a stimulus fading component where we start to fade in who's in the room, fade out people in the room based on familiarity, thinking about the number of people who's around, one person in the room versus, let's say, if I gave this talk in front of maybe 1,000 people, I might feel differently. So thinking about all of those kinds of elements. And we frame it to the kids as the goal is to increase your brave talking. A lot of kids like to be brave, and you can really ham this up, and depending on the kiddo, you can give them like bravery points and gold star for bravery and give them a brave talking certificate at the end. Again, depending on the kiddo and what they're kind of like and if that would be reinforcing for them or not. But that's really our goal. And just another point that labeled praise is important here, just as it would be. So having the child know why, you're not just saying nice work, you're really talking about that's some nice talking that's happening right there. I like how you use your words. So to break this down a little bit, these are the treatment phases. And again, just as a reminder, this is a treatment phase in selective mutism treatment in general. I'll talk about adaptations that at least I did for a kiddo with ASD that you might want to think about for your kiddos. So treatment is broken up into two phases. The first phase is really considered a warm-up phase. And that warm-up phase is called child-directed interactions. And it usually starts with the parent and child alone in a room, and the next phase will be the therapist in the room. And often this is done with the mirror, and sometimes we even do bug in the ear and coach parents along. There's a really big parent coaching element in this, which I like for generalization. And the goal is really to get the child comfortable in the kind of treatment room, not have any demand. So you would be so shocked at how many questions we ask each other as part of our social interaction. You just want to, as an experiment for yourself, take a minute sample and just either listen to yourself or listen to someone else and see how many times as part of your interaction you ask a question. How's it going today? What are you up to later? Do you want to sit here? We ask an incredible amount of questions. And so part of the idea is to really remove that piece, and there's no questions that are asked during this phase. And we want to have the room set up so that it is not a room where they're already going through that cycle and that loop. We do not want to set up our treatment room where we are asking the child a question by accident, just like we would our other patients or our other kiddos we work with, and then all of a sudden they don't answer, and we give them something. And then all of a sudden the treatment room is set up to be an area where they don't have to use their words. And so we really just let the kiddo and the parent play alone. We will sometimes coach the parent through the bug in the ear from the other room. We're watching, and we coach them to not ask any questions. We get them to describe what they see. So it's sort of like a sportcaster narrating the play. So it's like, wow, the truck is driving down the ramp. That's a big tower. I really like the blue ball that you're playing with. We get the parents to repeat anything the child says. So if the child does use words, they might not use any words, but if they do, you can repeat them and say, son, you said son. I like the way you're playing with that. Praising the child for using any words that you do see, and making sure there's no questions. That's probably the most important part. The second part of this warm-up phase is that the therapist enters the room. It's important that the therapist does not sneak up on the child. You think this is a child often has kind of an anxious temperament. Social anxiety is pretty common in these kiddos who have selective mutism. And you can just kind of come in and say, wow, I really love what you're playing with. Or you might comment on the play, or just give the child some time to warm up to the fact that you're in the room. And maybe you start kind of back and then gradually work your way up to the kiddo. And you do those same skills. You're following the child's lead. You're describing what they're doing. You repeat if they're saying something, and keeping things positive. The second treatment phase is verbal directed interactions. And this is where we really get into I would say, the meat of the treatment. And it's where we're trying to get kids to use their words. And really the goal is to get a verbal response from the child in this section. So after the warm-up period, we get into asking a very specific kind of question. So the things to remember in this section is even though we might be asking for questions, we want to start with sort of the easiest questions and from the easiest person. So forced choice questions. Do you want this or that? Do you want the ball or do you want the truck? That's an example of a forced choice question. They have to give some sort of answer, verbal answer, and they can't just use gestures. So that is why we also really want to avoid yes or no questions, which we ask a ton of in regular day-to-day life. But all of us can shake our head no or yes. And so again, it's almost unlearning that for ourselves when we get to this phase. So if I was to ask that question to a kiddo, and usually those things need to be something that the child really wants, otherwise you're kind of setting yourself up for failure. You really want to wait at least 5 seconds because these kids just take longer to get the communication part out. And then if the child does use their language for that, then you would give them the object right away and say some kind of praise. I mean, getting the object itself is naturally reinforcing, but also you can say kind of nice talking. There are aspects, if you want to break this down even more, this talking phase, verbal directed interactions, you're really introducing the speech in some way. So again, forced choice question. Eventually you can get to more open-ended questions. And then we do a lot of games with this work. So begin a game that requires talking. Games are fun. It has to be a game that the child likes to play and wants to play. And so Spot It is a really popular selective mutism game where they have to kind of match up cards, and there's a bunch of different objects on the card. So there might be a butterfly and a caterpillar and a truck and a ball, and there's a card in the middle and cards that all the players have. And whoever can spot a match on their card and the card in the middle and put it down and use a verbal communication to say what that object was. So if it was the butterfly that's a match, I have to put the card down and say butterfly. Then they get that card, and whoever gets the most cards wins. There's also bingo. So we have herds of kids. Right now there's a selective mutism group happening at BC Children's Hospital, which is a bunch of kids who don't have autism, to my knowledge, but typically developing kids aside from selective mutism. And they are running a group right now. It's a research study. And they will be herds of small little kids coming through with their bingo, and they have to practice asking questions on the bingo board that are already listed on the page, and they have to ask them to somebody in the hallway that they don't know or in the offices. And if the child asks that question, then they get a stamp for the bingo, and whoever gets bingo, then they win a prize. There is an explicit focus on generalization, so you change one thing at a time. So you don't change too many variables at once. You want to either be thinking about changing a person, a place, or an activity. You bring in new people one at a time and think about who's the easiest to who's the hardest. You want to play the game in different environments and do different kinds of activities. And then the very last step is the transfer of the control, or the pass the baton. So you want to gradually increase the role of others in this treatment as part of the therapy. So parents, teachers, and you start to become more of a troubleshooter, collaborator kind of role. So these are all really key aspects of selective mutism treatment. So there's definitely a parent coaching piece. There's office-based practice and community practice, so where the kids actually are, whether it's the playground or if they go to the mall. And the school piece is really big in this kind of treatment. Oftentimes it's the school where the kids are selectively mute and they're not talking, and that can sometimes be the area where they're losing out on the most skills. They're losing the peer interaction, and they're not able to show their knowledge to teachers, so they're falling behind on grades. And you know, I like to put this into context because sometimes people think, oh, is selective mutism that big of a deal? But you know, we have kids who are peeing their pants because they're too scared to raise their hand to ask the teacher to go to the bathroom when they have the ability to ask their teacher to go to the bathroom. I remember I watched Dr. Annie Simpson, who's a psychologist locally and has done a lot of work in SM. She did a talk on selective mutism. And she told the story about a young man who was drowning, and he had selective mutism. And he, even in the context of drowning, he could not use his words to say, ask for help. And that story sticks with me from a treatment perspective and importance of catching this in kiddos and not just saying, oh, I'm not sure, it's not my area of expertise, I'm not sure whether this is a big thing. If a child has language and they're not able to use it in certain environments, we know that a behavioral approach can help these kids, and it can make a big impact. So I'm going to show you a video about how some of this treatment actually looks like. And you'll see, this is from Anxiety Canada, so www.anxietycanada.ca. And they have a really great YouTube video called Understanding and Management of Selective Mutism. So let's see if I can get this to work. That is the big test for me.
Whenever he'd be somewhere he'd have a hard time talking, we would take some time, take him aside, and do something that would help him warm up to the situation. It could be anything he likes, building blocks, toy cars. Lee really loves to draw.
So we don't ask him any questions or tell him what to do. We just sort of talk about whatever he's doing and follow his lead. It's kind of like a play-by-play. I see you're drawing a big dog. A big dog with a hat.
And if he does say something, we repeat it back to him so he knows we heard him, but there's no pressure for him to say anything else. You're coloring the dog blue. That's my favorite color.
I know. That's why I picked it.
We thank him and reward him for talking anytime we can.
You know that blue's my favorite color. Thanks for telling me that's why you picked it.
So we warm up at school, before class or at his grandparents' place. Well, anywhere he needs to, really. We practice at home 5 or 10 minutes every day, just so we can be ready with those skills when we need them.
Slowly, he became a little less anxious and more comfortable.
Once Lee started to look more comfortable and his parents were feeling confident in their warm-up skills, they were advised to slowly encourage him to talk more directly.
So then, after we warmed up a bit, we started introducing some questions.
Questions have to be low pressure, so we can answer them, So, is that the sun? And no yes or no questions because he'll just shake or nod his head. Or is it a ball?
It's a giant cookie.
Oh, it's a giant cookie. I see that now. It looks just like one, huh? We do have to keep up with the warm-up behaviors, but it's working.
The forced choice questions are the easiest ones for him to answer. Red or blue or this or that sort of thing. But he's also pretty good with the open-ended questions, which is great because then it just encourages him to talk more. What color are you looking for, Lee? If you get stuck, you can always rephrase it as a forced choice question. I see you pointing, but which one are you looking for, the green or the yellow? Sometimes you have to wait a full 5 seconds.
Green.
I see, the green one. Here you go.
As Lee became comfortable speaking in new situations when prompted, it was important for his parents to continue to challenge him. This can be accomplished by moving closer to the center of a busy room, or even adding a new person.
When we started adding new people into the mix, the most important thing was really helping them understand. Once people had a sense of what Lee was going through and learned the do's and don'ts of how to interact with him, we were surprised at how willing they were, not just to learn, but to take an active role in his development.
So you start them pretty far away. Kind of ask them to be a fly on the wall. Start simple with those warm-up activities. You're starting a new drawing.
Yeah, I need a new page.
Thanks for telling me that you needed a new page. Then with time, if he's talking, you can move him closer.
And then, eventually, that person can start joining in with some of the same warm-up activities.
I see you're drawing something purple.
It's a pickle.
A purple pickle.
And if everything is going well, they can start asking questions too.
Is that a blue pickle or a yellow pickle?
Blue.
A blue pickle. Thanks for telling me that.
So if we ever get stuck or it's a harder situation than we thought, well, then we just work our way back up using those warm-up and talking skills.
And that's the great thing about this. You just start out with the most basic stuff. and slowly work up to the harder stuff. There's always something to fall back on.
Using these simple techniques of warming up and encouraging talking.
Okay. So I think that it's really great to have that video now that Anxiety Canada put out, because I think it does a really lovely job of actually showing more what some of those skills look like. And I'd encourage you to watch that full video because it's quite nice actually. So let's talk about adaptations for kiddos with ASD. And again, there is no specific research study on this, but I've done a lot of work in other research-based interventions that have been adapted for kiddos with ASD, like the Facing Your Fears program, which is an anxiety based program for kids with autism, and just lots of work in these areas. Although selective mutism, I've had far less experience with than autism, but I think it's important to just start to kind of move forward with some of these things, and knowing that selective mutism really is anxiety that is specific to speaking. So if you think of it that way, then it kind of helps break down some of those, maybe some blocks to maybe either assessing this or treating it. Some of the general treatment adaptations that have been helpful for working with kiddos with ASD is, I think it's really important, if there are past assessments, to get your hands on those to guide treatment and use those to consider appropriate treatment goals. So I really love getting my hands on SLP, speech language pathology assessments, to find out, okay, what is their language level? So what is their expressive language level? What are we talking, phrase speech? Are we talking like how many years behind in language are they using? Or maybe even asking parents, right? You could do a language sample and see, or ask parents to do a language sample and find out what is the most common level of speech that they're using. And then let's make sure that our goal for selective mutism treatment is consistent with what kind of speech they're actually using. Some people who don't really kind of get this piece could pick a goal that maybe is appropriate for a kiddo who doesn't have autism, but it's way too hard, and we're setting everyone up for failure. Visual schedules can be helpful if that's something that works for these kiddos. As most treatments for kids with ASD that are adapted, a lot heavier on the behavior side of things and less kind of cognitive-based strategies. The treatment length is longer, and so again, that's something important to think about, because even in the population of kids who just have selective mutism and are otherwise typically developing, those sessions are actually, there's about 20 sessions often that these kiddos need. And so often we might be thinking about 40 sessions for these kiddos. But you'll see in the case study that I did 20 sessions, and there were still some pretty substantial important outcomes to the family, ecologically valid outcomes for the family, even with 20 sessions. But that's a good rule of thumb, even when you're thinking about, let's say, applying cognitive behavioral therapy for kids with autism, that if, let's say, in the clinic working with kids without autism, I might spend 10 to 12 sessions. Often with a kid with autism, I'm often thinking about double that. And external rewards are really important, I think, for anyone. We all get paychecks when we go to our job. Rewards are important, and having rewards that are important for these kiddos, whether that's part of their special interests or something else, is really important, because talking is not super fun for these kiddos, even if they don't have selective mutism. Not for everyone, but a lot of these kiddos, they're still trying to learn that talking can get them things in the world, and that maybe the social aspect of language is not near as naturally reinforcing. And here we are, these kiddos not only have autism, so social communication is already different, and then on top of that, they have a specific fear of speaking in certain circumstances. And so we really need to up the ante and keep that in mind when we're working with these kiddos, to ask them to do these things that are like the hardest thing in the world. It would be like if someone asked me to go bungee jumping or something. You better hope that the external reward for me is going to be really high, because that's, for me, that's the equivalent of asking these kiddos to work on their speaking. So in terms of other kinds of things that I found that are more specific, so the last slide was more about just in general what we want to think about for treatment of these kiddos. And in terms of the actual selective mutism treatment itself, what I found is that the child-directed phase of treatment, the warm-up phase, was kind of a total bust. I'm not going to lie, because what for maybe a child without autism was sort of a fun period where they could independently play with all these cool things, the kids with autism, well, at least the kiddo that I had, was sort of like, I don't know how to independently play with these objects. They weren't really interested in free, unstructured time. And having their parents be with them to sort of look at what they're playing with or comment on whatever they're using wasn't necessarily that great. So the whole point of this phase is to have the child be comfortable and sort of enjoy the room and the experience. And really, this was just putting all these demands on this kiddo who had a hard time with independent play anyway. So this phase was very much shortened, and I think the more structured as possible that you can make this section, and having something that the child really likes in the room might help that. But what I found is that the next phase, the talking treatment phase, was actually much more enjoyable for the youth that I worked with autism, because he knew the structure, it had a plan. I coached him through exactly what was happening, versus this period, which really, I think in some ways almost increases anxiety, which is the opposite of what we're going for. The other thing is that pre-teaching is really important, and anyone who's in the autism field is thinking about pre-teaching a lot of time. But some of the problem with this field, right, is that there's either people who are really interested in autism but then don't have the selective mutism training or background, or there's people who really specialize in selective mutism at the hospital or in other community settings, but that don't have the autism lens. And so if you can bring these pieces together, again, you're ahead of 80% of the people out there. And so pre-teaching is really important. So instead of just, once a child, let's say, has practiced ordering something, maybe we've worked up to, we've done forced choice questions, maybe we've done open-ended questions, we've practiced in the room, we've practiced with familiar people, and now they're ready to go order something in a really not a busy coffee shop or something. And you don't want to assume that just because a child is 14 years old that they know how to order something, especially in this population. So taking some time to ask parents about that, or pre-teaching what you're going to ask for, giving kids scripts, all really important, because this can break down really fast if we make some wrong assumptions about skills that they don't have. And then not only are we asking them to talk, we're asking them to try to learn a new skill on the spot. The generalization is really important in this kind of treatment anyway, but it's even more important, as we know, because kids with autism have trouble with generalization. So that piece is even more important for this treatment. And then incorporating special interests into treatment is important. Again, this is something we're learning more and more in the autism field, that in the past we used to try to get these kids to stop having their special interests. But now we're like, you know what, we should use this. This is a motivation tool that we can use and we should think about, especially when it comes to the rewards. So I think the big things that I want for all of you to go home thinking about is that, just first of all, knowing selective mutism is a thing. Selective mutism can co-occur in autism, and it's often missed. And whether or not you need, I wouldn't say you necessarily need to wait for an official diagnosis or have a kid go through the long, arduous diagnostic procedures. If they can get that, great. But if you notice that one of the kids that you're working with is not speaking in some settings that are important for their development, and you know that they have that language ability in other settings, and you have a behavioral background, what's the harm in working on it? And so many people are so scared to work on this because they say, oh, I either don't have the selective mutism training, or they say, oh, I don't work with autism. I don't feel comfortable in autism. And so a lot of people who are watching this are more comfortable in autism. And as you can see from what I described, is the selective mutism treatment is very behavioral, which so many of you have those skills. And so I would just really urge you to think about this, consider treating it from a behavioral approach, and assess, just like you would with all behavioral goals. Is this working, is this not? And change things accordingly. And it's so important because these kiddos, they already have deficits in adaptive functioning and social communication differences. So if we can increase their ability to use the language that they do have, that you've probably worked so hard to get them in these different environments, then we should do that. And you can feel like this is something you can really make progress on as well. So treatment, again, should be behavioral, systematic, focused on increasing that functional speech. Often the anxiety may come down as well, but not always. But if you really focus on the increased functional speech, then that's really important. A couple of resources that I really like. So the Child Mind Institute is just a fabulous resource for lots of things, but they have a selective mutism. They have a whole website on selective mutism. It's not specific to autism, but it still has some great stuff there. Dr. Annie Simpson gives a great talk about selective mutism, and again, not specific to autism, but still great background in that. The Anxiety Canada website, so I put the link on the slide to the video that I showed. And the Treatment That Works series book is by Lindsay Bergman, who is one of the people who did the randomized control trials. And so that is a big part of what the work that I did and showed you is based on, as well as Dr. Stephen Kurtz. And so again, we still need lots more work in this area. If someone's out there trying to do a study in autism and selective mutism, then I would be thrilled to see that work done someday, or that research. But in the meantime, just really wanting everyone to think about catching selective mutism and not being afraid to look at a behavioral treatment approach for this. So I think we have a few minutes here for questions. If anyone has any thoughts or comments or just general thoughts on this topic, happy to discuss.
Questions?
Yep. I was wondering if there were any setbacks in your case study with Dan. Did you have any moments where you took a step backwards?
Yeah, that's a good question. It's been a couple of years now, actually, since I've worked with Dan, so I was reflecting back. I would say that some of the setbacks that can happen in this population, and some of the things I can think of is when I first started doing this work, I still caught myself asking questions, even when I knew I wasn't supposed to. And so just having some really, it's good to have supervision anyway in your career and have people watch you and offer advice on what you're doing. So watching, I did slip up and say some questions that he wasn't yet able to answer. And I'm trying to think, with Dad, it was slower going than I was expecting. So I was sort of surprised that he was able to speak faster with me. And there was this feeling of, gosh, we need to make sure that this dad is able to talk with his kid by the end of treatment. And you could see Dad was working so hard, and he's bringing him to every session. And he was slower to speak to Dad, so we had to go slower with Dad than I think we were expecting. So Dad spent a lot of time outside of the room, and Dan just practicing answering questions with Mom and then with me, and then Dad would get a little bit closer, and sometimes he'd go too close and Dan would kind of shut down, and so we'd have to kind of go back a bit and get real. So going slower, I think, than I expected, especially for Dad, was tricky. And then the question piece. I ask so many questions in my day-to-day life. Yeah.
So with the forced, I understand why you want to start with forced choice questions.
Yep.
and allow sufficient latency because it may take 5 to 10 seconds to answer.
Yeah.
But what if there's no answer at that point? What if you can't get it even started?
Yeah.
How do you deal with that?
Yeah. So so there is sort of a protocol that you can ask again and wait another 5 seconds. And if that happens and you can't get any answer, then what you try to do is you try to go back to something they've already done before. And kind of backpedal. If there's like never been any language whatsoever that they've used at all in that space, then you go back to the warm-up phase typically. With autism, it's a little bit trickier because that phase wasn't so reinforcing for Dan. But in theory, you go back to taking all demands off and describing the play and just hoping for something spontaneous. And you can get the kiddo to, if they're willing, usually there's one person they're willing to talk to. And if you give it enough sessions, it might be that you're spending 5 sessions just having the kiddo come in. You feel like you're not doing any therapy, but they're just interacting with the parent with really fun stuff, and you're just describing their play and having to get really comfortable. And coaching Mom with some of these skills through the mirror and through the bug in the ear. And they can even get started by whispering the answer in their mom's ear is another way to kind of go back. Usually if you go...
So you ask the question, and the child whispers the answer to mom, who then tells you the answer, but at least you know that the kid is talking
Exactly.
to someone.
Exactly. Or we even start with, I'm behind the mirror, I see the child and the mom in the room, and I whisper to mom with the bug in the ear, ask this forced choice question. So, do you want the blue crayon or the red crayon? Actually, that wouldn't be a good question because they have to say two things. Do you want the ball or the truck? And so I might whisper that to mom, who then says that, and hopefully the child will answer to mom without anyone in the room. Or, yeah.
I mean, outside of the kind of context that you're in,
Yeah.
nobody has
Wow.
one-way mirrors.
Yeah.
Nobody has bug in the ear.
Yeah.
Right, so that's why I think it's important to think in a real-world setting, how would you manage that?
It's a really, really good point. It's a good point because a lot of times that room was not even available sometimes at the hospital. And a lot of time, it is somewhat surprising when even the kids with diagnosed selective mutism who come in, if you give them enough warm-up period and you take away all questions and they get really comfortable, usually you can get a little bit with a familiar person in an unfamiliar setting. And, I guess the other possibility is to, if you have the flexibility, to go do that warm-up period in the child's home with the familiar person and see if you can kind of be almost out of the frame but still present for that piece. But yeah, these are some of the troubleshooting you kind of have to do for sure.
Interesting.
Yeah.
Yeah, I'm kind of thinking about the school intervention piece.
Yes.
Often the setting where it's the most difficult, and
Yeah.
I'm thinking about, a client in high school, and how would I do this process at school in a high school setting? What would warm up look like? If you'll speak to me in other settings, do I need to do the whole warm up with me in school and then slowly fade in the teachers? Or
Yeah.
do you have any tips or details about that part of
Yes.
the intervention?
Yeah. So first of all, bravo for trying to do this work. And then, just having for yourself realistic treatment expectations, because if someone's in high school and has a period of, that's however many years of not speaking in that setting or very minimal speaking in that setting. So I would for sure go slow. And if he's speaking to you in other settings, then finding the area at school that is the least busy, that he's most comfortable in, and having him warm up with you, even though he speaks with you in other settings. And then if he does start to spontaneously use speech with you in that setting, then great, you can start to kind of move through some of the stages. But yeah, I like eventually having, in high school there's some other options where you can, if people want to have buddies or lunch buddy programs where maybe they can talk about his favorite topic, or you can kind of have some coaching that might be happening with the kiddos there. But I would say go really slow and kind of, in high school it's tricky because you kind of want to find like one person or two people who might be really invested in his interests. But I've worked in elementary schools, and if the elementary school is invested and they see the problem and the parents are advocates, and you kind of phrase it as, I'm giving you training that's not just helpful for this one kiddo, that can help for other kiddos in your class, then a lot of times teachers and EAs are open to it. But each school culture is a little bit different. Yeah.
With the kids that you've worked with, or selective mutism in general, do the kids seem to have some sort of enjoyment of social engagement or desire to social engage exclusive from speech?
It's such a good question. So oftentimes the typically developing kids will have that a bit more, although they have a really high rate of co-occurring social anxiety disorder on top of selective mutism. So that's another layer to things. Oftentimes the kids with autism, it's a mixed bag, and we shouldn't assume that that they are motivated, as you know, to necessarily interact with a lot of people.
So would you spend kind of longer in the beginning just getting them enjoying or willing to just even be with the person, or playing silently with the person before that kind of speech bit is put on?
Absolutely, and I just like even the way you're thinking about this. So the fact that and that's the benefit of having such a great ASD lens, is you could be thinking about some of those things.
About the kids that don't want playing with me.
Exactly. So it's like, okay, first thing, I'm like, I know this kid doesn't like to play with me. So what do they like to play with? What can we ask parents that they know that this would really, so that you can be paired as something that's reinforcing. And I think in theory, that's what that initial warm-up phase should be for, right? And so maybe that, maybe I could be using that phase differently and better as more of a testing of reinforcements and kind of cool things for the kiddo, so that they do want to socially interact with you in some way that they, based on where their skills are at. But it is something that, like, I'm glad you're thinking about that, because it is something that adds another element to this treatment to think about.
And then one more question.
Yeah.
With kids that develop to when they're older, is there kind of some research on, like, there's sort of the negative reinforcement cycle of why it keeps happening, but for that kid who was 11 and hadn't talked to his dad in 2 years, like, I'm assuming he had before, like, did they kind of know why or how his speech started, like, fading back?
It is really interesting. I don't know the specific research on it, but I think there is some old wives' tales out there that, maybe there was trauma, or maybe there is, maybe trauma, or maybe other kinds of things. There's a big reason why they stopped talking, but there's no research to suggest that that's the case, that it really is an anxiety disorder just like any other anxiety disorder, and they can just, you think of temperament, you think of genetic contributions, and maybe that there's someone in the family that doesn't have selective mutism, but maybe there was a lot of separation anxiety when they were younger, or other kinds of anxiety, and then in this particular kiddo just manifested in the selective mutism area, combined with that cycle that happens. And I think that cycle happens more often in our kiddos with ASD anyway. I'm constantly talking to parents in my clinical practice about what's excessive protection, what's adaptive protection, right? There's a lot of times it does make sense to protect these kids more than maybe your other kinds of kiddos. And there's other times we get so used to overprotecting these kids that we really make them lose out on really important learning opportunities. So I think it's a combination of those things, yeah.
I was just sorry, I arrived late. I was just wondering if you wouldn't mind going back to the cycle slide.
Yeah, absolutely.
And then with regards to the bug in the ear, just another ideas have coached others, not related to selective mutism, but coached parents dealing with problem behavior just through texting or instant messenger.
That's
because
pretty
we
neat.
don't want to talk in front of the child at that time, so that might be a workaround.
Oh, I love that. This is why I love these presentations, right? It's like I feel like when we do these things, it's more like, I'm not here talking because I feel like I'm an expert in selective mutism treatment, not at all, but it's more like I was willing to messily, venture into this area, and let's have a conversation about this as a group. And so I love that. I think text message and instant messaging, from a research lens, I think we're kind of behind sometimes in thinking about some of these adaptations. And that's a really beautiful example of how to do that without the bug in the ear.
Well, I've also seen people do it with the Bluetooth, right? So the coach is on the phone, and the parent's wearing a Bluetooth. Right. And you're basically having a phone conversation, only
I love that.
From, I can see outside the room, right? You're using, like, technology that isn't meant to be used that way, but that's the way it's being used. It's basically bug in the ear, except it's Bluetooth in the ear, right?
I love that. Here's the cycle, which I think also is really nice to use as a clinical tool when you're working with families. When you really map it out this way, they can see, and it's not blaming. It's more just like, look, you're stuck in this cycle, and it's not your fault, and it makes sense that you haven't gotten out of this cycle yet. And we're going to find ways we have to break some link in this cycle, and that's what I'm going to teach you and coach you to do in a gradual way. Essentially, you ask a question, anxiety spikes in the kiddo, child avoids answering the question, they're just silent. The adult jumps in because this is really uncomfortable. I mean, I was that person. I don't like when no one answers a question. I'll be the first one to jump in and answer the question. Or gives the child a cookie if the parent asks, hey, do you want a cookie? Everyone feels better after the child gets the cookie and the question's answered by an adult. And then the next time a speech demand comes up, child's anxiety spikes, same thing happens.
Other questions? Okay, well, help me thank Ainsley. This is great.